Hello, everyone. This is part two of our series on stroke awareness, focusing on asymptomatic atherosclerotic carotid artery stenosis. We have already talked about how a major stroke can be devastating for patients, their families, and society. So, it is super important to prevent strokes, whether someone has symptoms or not. That is why stroke prevention is a big deal for research. Key studies have looked at this specific issue and the results have shaped the recommendation we use in our clinical practice guideline, which we follow every day. We don't usually screen the whole population for carotid artery stenosis, but we do target screening for people who are at higher risk. For example, men over 65 with multiple cardiovascular risk factor, especially those with coronary artery disease, especially if they have had a coronary artery bypass or coronary artery stenting, patient with peripheral arterial disease, patient with carotid artery occlusion on the other side, and those with a previous carotid endarterectomy or stenting. Duplex ultrasound is a screening tool we use for carotid artery stenosis. If the stenosis is less than 50%, we start the patient on best medical therapy and we don't need regular follow-up unless there are high-risk plaque features like ulceration, intraplaque hemorrhage, microemboli, or instability on the transcranial Doppler. But if the stenosis is more than 50%, we also put the patient on best medical therapy in addition to a surveillance program watching for progression, especially if stenosis reaches 70 to 80% new embolic signals or plaque instability. We schedule intervention when asymptomatic carotid artery stenosis reaches 70% and the risk of surgery is low, with life expectancy more than 5 years and there is no major comorbidities. Or if the stenosis is more than 70% and the plaque has a high risk of instability. When deciding on the best way to revascularize, it is important to consider a few factors like the heart and lung condition and if there is end-stage renal disease. Also, it is good to know if there is a history of surgery involving the neck like stomas or radiation. Lastly, a CT scan of the aortic arch and carotid arteries can give us a good look at the anatomy, including the arch type or any atheromas, carotid calcification, and the level of bifurcation. We also check for any bilateral stenosis or tandem lesions. There are several revascularization options, such as carotid endarterectomy, whether eversion or patch technique. To make sure we are on the right track during the procedure, cerebral monitoring is super important for figuring out when a shunt might be needed. So, carotid endarterectomy can be done with regional anesthesia with a squeaky toy in the patient's other hand to track neural status. Or if it is done under general anesthesia, we use EEG, somatosensory evoked potential transcranial Doppler, near infrared spectroscopy, or even measure the pressure at the carotid stump. Abnormal reading requires shunting is called selective shunting. Otherwise, routine shunting is adopted by those with no access to those equipments. Carotid artery stents are another treatment option with access through the femoral artery, radial, or carotid artery. Carotid endarterectomy is often considered the gold standard, and generally transcarotid artery revascularization is preferred when stenting is a choice, as it tends to be less risky than the transfemoral approach. This is because it avoids manipulation of the arch with potential emboli or system instability, and this is supported by high-quality evidence-based studies. In general, both carotid endarterectomy and stenting for people without symptoms are considered low-risk vascular procedure. However, if the high symptoms are present, it is considered an intermediate risk procedure. When dealing with complex cases like asymptomatic carotid artery stenosis with coronary artery disease, we usually address the coronary artery first. And if there is bilateral asymptomatic carotid artery stenosis, we focus on the more severe side first. And if the stenosis is equal on both sides, we give priority to the dominant hand. I hope this was useful and informative. See you in the next lecture.